Welcome to the first Border Legislative Conference virtual session. I'm excited to see so many faces with us today. I'm California State Assemblymember Jose Medina, joining from Riverside, California, and I am the chair of the Border Legislative Conference. As many of you know, due to the continued impacts of COVID-19 pandemic affecting both the United States and Mexico, as well as the entire world, we made the difficult decision to postpone the 33rd Border Legislative Conference that was scheduled to convene this year in Riverside, California. The BLC serves a binational forum for legislators to exchange best practices and identify policy solutions that address the complex issues inherent to our border region. While we were not able to convene in person this year, we will be honoring members' requests to facilitate binational discussions during this evolving crisis through a virtual format. Details for the other virtual discussions this year will be forthcoming soon and will be available at the Council of State Governments West website. This morning, we're going to hear presentations from Coahuila, Mexico, Arizona, and Texas. Today, we will be discussing the very important topic of health along the border during this pandemic. It is my privilege this morning to introduce our speakers for today. First to present is Dr. Roberto Bernal Gomez, Secretary of Health for Coahuila, who was appointed by Governor Miguel Ángel Riquelme Solís in 2018. Then we will hear from Roberto Guerrero, Chief of the Office of Border Health with the Arizona Department of Health Services. And finally, we will hear from David Gruber, the Texas Associate Commissioner for the Regional and Local Health Border Health Emergency Preparedness and the Texas Center for Infectious Disease. Dr. Bernal, the stage is yours.
Muchas gracias. Pasamos la primera, la minilla, por favor. Voy a tratarme de ir rápido porque el tiempo es restringido. La que sigue, por favor. La siguiente. El estado de Coahuila es un estado, es el tercer estado más grande del país. Tiene 3,5 millones de habitantes aproximadamente. Nosotros hemos tenido 26,279 casos positivos, 1,150 activos, 315 hospitalizados, desafortunadas 1,752 defunciones, que es menos de un 5%, y hemos realizado 161,615 estudios. La que sigue. La que sigue, por favor. ¿Podríamos pasar a la siguiente? ¿Qué cara? ¿Podríamos pasar a la siguiente laminilla? Adi, ¿podríamos pasar a la siguiente laminilla?
It's frozen. Give me one moment, please.
Pásamela. Pásamela la diapositiva tú.
No tengo fórmula.
No, bueno, pues voy hablando.
¿Cómo?
Voy hablando yo.
No, es que no ve esto.
Bueno, pásame mi...
¿Sabes?
¿Qué hago, Adi? ¿No pasan las siguientes laminillas?
Sí, es que está congelado ahorita por el momento, pero...
The slideshow's frozen. I'm trying to unfreeze it right now.
Bueno, la sigo sin laminillas.
Si usted se siente a gusto, y claro, puede seguir.
A mí me preocupa el tiempo, Adi, nada más. ¿Se congela junto con el tiempo o prosigo?
No, puede seguir, por favor, sí.
Bueno, tenemos una métrica de indicadores nacionales y estatales. En esa métrica etiqueta rojo, naranja, amarillo y verde. Desde hace varios meses estamos trabajando con empresas consultoras como es McKinsey y revisamos la tasa de contagiosidad, la incidencia de casos nuevos, la tasa de mortalidad, la tasa de hospitalizados, de camas ocupadas, de camas con ventilador, de porcentaje. ¿La que sigue? Si me pueden pasar, esa, ahí voy. Bueno, estos son todos los indicadores que se establecen. Son los mejores indicadores internacionales que hemos encontrado. De los 4 colores, nosotros estamos en amarillo. Se ha manejado bastante bien la epidemia. La tendencia de casos nuevos va francamente para la baja, así como la tendencia de ocupación hospitalaria. La que sigue, por favor. Dentro de las estrategias, si podemos pasar a la que sigue. El estado es grande, es el tercer estado más grande de la República, y el gobernador dividió el estado en 4 diferentes regiones. Cada región es en 5. Cada región es diferente por sus condiciones geográficas, por sus condiciones particulares. Es muy diferente la frontera a la sureste, a la región lagunera. Esta región está representada por el gobernador, por un representante del gobernador, presidentes municipales, jefes de jurisdicción, directores de hospitales, ejército, Cruz Roja y empezar organismos empresariales. Y ellos toman sus propias decisiones, que pueden ser diferentes unas de otras. La que sigue, por favor. La que sigue, por favor. Como primer paso, hicimos un confinamiento obligatorio en el inicio de la pandemia. Solamente las actividades esenciales se permitían. La que sigue, por favor. Establecimos por decreto el uso obligatorio de cubrebocas en todas las poblaciones del estado. La que sigue, por favor. Hicimos intercambio internacional con Corea del Sur, con España, con Italia, con Francia, y eso lo repetimos cada 15 días. Nos comunicamos con los más expertos y nos transmitimos las mejores experiencias o las malas experiencias para mejor del estado. La que sigue, por favor. La estrategia es la que sigue. Las estrategias que Coahuila implementó fueron muestreo masivo, georreferencia, rastreo de contactos y estancias de contención. La que sigue, por favor. Quiero decirles que, la que sigue, por favor, que nuestro estado ha tomado 5.031 muestras por cada 100,000 habitantes. Es el estado que ha tomado más muestras, 4 veces más que el resto del país. La que sigue, por favor. Hicimos un estado, la que sigue. Hicimos una georreferencia, de tal forma que nosotros tenemos control de todos los pacientes infectados. Los que pasan 14 días infectados se convierten en amarillos y las desafortunadas defunciones las podemos localizar perfectamente por edad, por teléfono, por localización geográfica, por todo. Eso lo tenemos hasta el momento. La que sigue, por favor. Formamos, dentro de los ejemplos más importantes fue Nueva York y Alemania. Hicieron rastreadores. Hicimos las infotecas universitarias que no se podían concentrar los alumnos, las convertimos en call centers. Hay trabajadores de salud, empleados municipales, pasantes. Están coordinados por los subcomités y están entrenados en la transmisión y usan los equipos adecuados. Sus acciones son entrevistar el caso positivo, muestrear el caso sospechoso, aislar contactos de alto riesgo e informar reportes a pacientes y autoridades. La que sigue, por favor. La que sigue. Se tiene una evaluación de riesgo y se etiquetan mínimo, mediano y serio. El mínimo es con seguimiento virtual, lo seguimos con llamadas telefónicas. El regular, vamos y lo visitamos al domicilio. Le tomamos oximetría, le tomamos signos vitales. Empezamos a ver que muchos pacientes se acostumbraban a la hipoxemia y llegaban tardíamente al hospital y no morían. Para eso llevamos el oxímetro a la casa. Y los que están más graves los llevamos a atención urgente a la que sigue. O los llevamos, la que sigue, por favor. O los llevamos a una estancia de contención. Estas estancias de contención son centros deportivos en donde albergaban a muchos deportistas que por la epidemia no se pudieron utilizar. Entonces, lo usamos como estancias intermedias. La que sigue, por favor. La que sigue, por favor. Estas estancias intermedias tienen concentradores de oxígeno máximo están manejadas por personal de salud, están creadas para casos leves o moderados pre o post-hospitalarios. Hay pacientes que solamente requieren aislamiento porque la pareja está contagiada, no pueden ir a comprar víveres, entonces ahí los albergamos, hacemos cuidados médicos, aislamiento, sistema de traslado, y esto nos ha disminuido la estancia hospitalaria en un 30-40%. La que sigue, por favor. Esta que sigue es muy importante. Yo quiero que vean cómo con esta rastreador de contactos, cuando activamos la economía, subió la epidemia. Una vez que empezamos a trabajar con los rastreadores, empezamos a bajar hasta límites muy, muy inferiores. Estos son los casos de acuerdo a esta evolución. La que sigue, por favor. De la misma forma, las defunciones, una vez que estamos rastreando los contactos, nos han disminuido en forma muy importante. La que sigue. Ahora con la reapertura escolar, uno de nuestros objetivos es que cada director de escuelas, que son 3.500 escuelas, sea un rastreador. El día de ayer hicimos el primer evento, tuvimos 929 participantes. Para el fin de la quincena, esperamos ya que todos los profesores, directores de las escuelas, sepan detectar un paciente con síntomas, sepan cómo aislarla, sepan a dónde comunicarse, sepan cuáles son los contactos de alto riesgo. Esto lo vamos a hacer como algo único que no se ha repetido en el país. La que sigue, por favor. Finalmente, la que sigue, las indicaciones que son reapertura progresiva de cada una de las entidades, desde hoteles hasta centros nocturnos, eventos masivos, centros religiosos. Aquí ven cómo está perfectamente establecido por cada uno de los subcomités, por cada una de las regiones del estado, en rojo cuánto podamos abrir, naranja, amarillo y hasta finalmente verde, donde podamos abrir todo. Nosotros en el estado como tal vamos en amarillo. La que sigue, por favor. La que sigue. Esto ya específicamente de la frontera. Las cadenas productivas y exportaciones, Piedras Negras se mueve entre un 7-12% del comercio exterior del total de la mercancía de México. Cruzan 1.700 vagones y por Isle Paz cruzan 1.000 peatones, 8.000 vehículos y 700 trailers. Y ya la última, la que sigue, por favor. Para finalizar, pasamos la última. Para finalizar, la que sigue, por favor, tenemos los retos específicos. Si podemos pasar la última, que al cabo ya es la última. Los retos específicos para los estados fronterizos son la movilidad de ciudadanos, movilidad ligada a actividades laborales e importación de casos positivos COVID, importación para un lado y para otro lado. Las cadenas productivas, traslados de bienes a lo largo de la frontera debido a la integración económica, restringir actividades sería muy grave para la afectación económica y la familia, visitas interestatales entre familiares. Quiero acabar con dos preguntas que nos deben interesar. ¿Cómo intercambiar información y definir cercos sanitarios fronterizos? Y finalmente, otra cosa que creo que es importante, ¿cómo atender la situación de salud en los migrantes? Muchas gracias.
Muchas gracias, doctor Roberto Bernal. We'll now hear from Roberto Guerrero, Chief of the Office of Border Health within the Arizona Department of Health and Services.
Thank you very much, and I want to thank you all for this invitation to talk today. So as stated, I serve as the Chief of the Office of Border Health for the Arizona Department of Health Services. In addition to serving as our Director's Delegate to both the United States-Mexico Border Health Commission and the Arizona-Mexico Commission. So the role that the Office of Border Health has played since the inception of this pandemic has really centered on maintaining communication between the state of Arizona and the state of Sonora and Mexico as a whole through our commissions and then through our personal relationships between the Arizona Department of Health Services and the Secretaría de Salud for the state of Sonora. Early on, we identified the importance, the need of credible information. As you all recall, the amount of false information that was flying back and forth through social media. When we look at emergency preparedness, it really has its basis on the understanding that we're getting credible information at all times. And so I made the commitment from my office with Dr. Gerardo Alvarez, who's the Director General for Health Promotion and Disease Control for the state of Sonora, that we were going to share information on a daily basis, real-time information, both northbound and southbound. On a daily basis, Gerardo sends me his aviso epidemiológico, which is their state report with accurate, up-to-date information down to the municipal level. And I send him a situational awareness report on a daily basis southbound. And the idea is that we're keeping each other informed at all times of any issues that we're having. I share that information in Arizona with our border counties, with our public health emergency preparedness folks, with law enforcement, with Border Patrol, CBP, our Arizona National Guard, so that we at all times have real-time information about what's going on. This has been extremely important. Early on, there was a real worry about a surge of potential patients that would come northbound across the border. But by having this information on a daily basis, we were able to show that this type of surge was not going to happen, and that Sonora, our colleagues in Sonora, were more than able to deal with the situation. So what we are able to monitor on both sides of the border hospital capacity, and so that's helped us quite a bit. Arizona uses an epidemiological system called MedSys. It stands for a Medical Electronic Disease Surveillance Intelligence System. And this system we actually have the state of Sonora on our system. So we have approximately 15 different epidemiologists in the state of Sonora who are on the MedSys system. And this is how we are able to share case information across the border, so that the epidemiologists on the Mexican side also have access to laboratory results and clinical information on patients. One of the things that we started soon after the pandemic were weekly border health Zoom meetings between the Arizona Department of Health Services, the Secretaría de Salud de Sonora, the health jurisdiction directors on the Sonora side, the county health directors on the Arizona side. And oftentimes when you look at numbers, they don't tell you the whole story. And so what we were looking for was additional information, even anecdotal information. And we were able to identify issues that were going on that our numbers didn't show us. And part of that was a border dynamic that exists really border-wide. And this dynamic is that population, the number of US citizens that live on the Mexican side and work on the US side, or those people that live on the US side and work on the Mexican side. And even though there are restrictions in our borders to non-essential travel, this movement, north and south, was considered essential travel. But from an epidemiological standpoint, think about it as a tide going in and out, and people crossing over back and forth every single day. And so, we really needed to look into how we could take that into consideration on issues that we were seeing. One of the things that we were able to identify was the need for more epidemiologists on the Sonora side to understand, be trained on our medicine system. So we were able to do some virtual training to bring on board more epidemiologists from Sonora. And this assists us in the contact investigations that we're able to do. Another thing that we were able to do was we identified that in Sonora, one of the issues that was happening was that the flow of patients from rural communities to larger communities, for instance, Agua Prieta, Sonora, normally would send their patients to Nogales. Nogales would send their patients to Hermosillo when they need a higher level of care. But when the system starts to, same thing was happening in Arizona, when our urban hospitals start to get saturated, then suddenly Nogales cannot send a patient to Hermosillo. And if Nogales can't send a patient to Hermosillo, that means that will send a patient. And so we started to see rural communities that were having to treat more critical patients in place. And the same thing was happening here in Arizona, but we have a little bit different system here. And so there was a need for the rural hospitals of Sonora to understand ventilator management. Consider a physician who is working in a rural community who maybe the last time he took care of a ventilator patient was 15 years ago in med school. And suddenly they're being asked to hunker down and take on. So we did some virtual seminars on care of ventilator patients in adults, care of OB patients that have COVID, and the care of pediatric patients. And we were able to do these because those were identified in those weekly calls that we have. So, you know, when we talk about the non-essential travel that CBP, or actually that the United States and Mexico have agreed on, we're still seeing that's still something that is an issue, because we're seeing southbound travel not be as restricted as we would like, and this has an effect on our colleagues in Sonora. Let's see. I'm going to go ahead and stop there. I think I've kind of painted the picture. The biggest key is having real-time information as much as possible, having credible information, rumor controls. We had rumors that hospitals were being closed down in Mexico, which was not true. And so it's really having that ability to have information as soon as possible and make sure that it's credible. Thank you.
Thank you, Robert. And now we're going to hear from David Gruber, Texas Associate Commissioner for the Regional and Local Health, Border Health Emergency Preparedness, and the Texas Center for Infectious Disease.
Thank you, Representative, and again, good day to all. What I'd like to do is go over a little bit of what we saw in Texas regarding the border area, and I'll divide that into two separate types of conversation. One is the impact of the border population on the Texas side, which is unique to Texas and very different than the rest of Texas. And the other is the binational aspect. So along the border and all the way from Brownsville all the way to El Paso, unfortunately, we do see higher levels of obesity, cardiovascular disease, than diabetes. And as all of you know who are in public health and those who are involved in COVID, those underlying diseases contribute significantly to how a patient will react to after infection with COVID. In addition to those factors, there's a significant number of uninsured in that area. And you'll see where I'm going with this in a few minutes. I'll also add that the strengths of the Hispanic population, those strengths being family unity, independence, and pride, contributed to those folks not necessarily showing up at a hospital as soon as perhaps we would like them to. So if you look at the combination of the underlying physical and behavioral health aspects of the population in general, if you look at the population being obviously largely Hispanic in that area, what we found was that a large number of those presenting to our facilities, our hospital and healthcare facilities, waited till the last minute to get to the hospital. That they were more severe as far as their symptoms, and that because there was this rush to the hospitals at some point, the hospitals became backed up, and the downstream impact was that EMS was having to wait sometimes, and EMS ambulance sometimes had to wait up to 5 hours before being able to discharge the passenger into the hospital. That backed up into the community where there were not enough ambulances in the community, and the population lost faith in calling 911. What we wound up with was, as you can imagine, an overwhelming number of cases in our border area with high hospitalization rates and unfortunately higher death rates than we saw in most other places. The way that Texas addressed that issue was that we poured a lot of healthcare providers into the healthcare facilities to provide surge capacity. We also added additional ambulances, both from within Texas and also through federal contracts to that area. And at one point, particularly with our Laredo facility, we had to transfer patients to areas beyond the Valley and Laredo so that we could relieve some of the pressure on our hospitals. So it was not the best of circumstances. We wish it had been better, but I wanted to paint the picture of what was going on in the border area. So now let's quickly talk by national. We relied heavily on the existing relationships that our cities, our city health departments had with our cross-border partners, that our regions, our public health regions had with our cross-border partners. It was more done at the local level than it was done at the Texas state level. We also had our existing binational tuberculosis program, which laid the basis for discussions and contacts that previously existed. And our Office of Border Public Health also contributed to that. So as we move forward, we feel we will continue to rely on our existing excellent relationships at the local level to provide the communication back and forth. I will say that we did not see a significant influence on disease from Mexico to the United States. That was not a factor. So the reduction in people going across the border and also in the vigilance of those who did come across the border both ways, I think contributed to that not being a factor in the disease spread. So with that, I'll stop and see if there are any comments, questions for any of us at this point. Thank you.
Great. Well, thank you, Chairman Medina. And then also thank you to our great speakers, Dr. Bernal, Mr. Guerrero, and Mr. Gruber. We would like, in the interest of time, I noticed that some of us joined a little bit later. So if you have a question or decide to join us for the discussion and didn't get a chance to introduce yourselves, please state your name, your state, and where you're calling from, So now we would like to open it up to a discussion, a Q&A. So if you have any questions for our speakers, please feel free to speak up. Thank you. Senator Sols.
Thank you, Addie, and speakers. It was wonderful. One of the things we deal with in New Mexico, and I know along the border, is very much the outbreaks of COVID that have been in the ICE detention facilities. And I'm curious, in Texas and Arizona, who has jurisdiction over those, and how have you managed the outbreaks in those particular ICE detention facilities? And when there has been an outbreak, are people deported back to Mexico and other places, or are they kept until they are cleared of COVID?
Speaking from Texas, I think we were very fortunate. We did not see large outbreaks in those facilities. I think there was a significant reduction in the number in those facilities compared to pre-COVID. And the federal government, for our purposes, were the ones that handled all of it. They did not put any burden on Texas in that, for that particular population for COVID-19.
And speaking for Arizona, the local county health department, in our case, it would be Pinal County Health Department, took the lead on that. However, main jurisdiction is at the federal level with our detention facilities. As far as if they were deporting any COVID positive cases, I don't really have that type of information. It's not really shared as much as we had some anecdotal information from Sonora stating that they occasionally would get somebody, but I don't really have any factual information I can share.
Thank you.
Tengo una pregunta para el doctor Bernal. ¿Cuál fue la pública que más impacto tuvo en su entorno?
¿Me la puede repetir, por favor?
Claro, ¿cuál fue la política pública que más impacto tuvo en su estado?
Muestreo masivo. Si hay muestras, hay diagnósticos. Si hay diagnósticos, hay cercos sanitarios.
Adi, I have a question. What are the most common misconceptions about health efforts along the border that people have, and how can we combat these misconceptions and communicate more effectively? And the question to all the panelists.
Speaking for Arizona and our colleagues in Sonora, from the public standpoint, and within the age range of the 20 to 44-year-old age range, the biggest misconception is that this was not a serious issue, and it continues to be the same, at least here in Arizona. That folks are just not taking it seriously. The dynamic that we were seeing on especially weekends, because I was getting calls from our county health directors asking, you know, they were frustrated because there were lines of people that were going into Sonora for the weekend for carne asadas and then coming back, and these were people that were U.S. citizens, so they were allowed to go in and then allowed to return. And so I think that's been the biggest misconception. So we've tried to tailor our messaging to this group of, you know, when you talk about family unity, so you try to strike home with that and say, you know, how would you know, this isn't about taking care of yourself, but it's about taking care of your mother, your tia, you know, your relatives, and how much you cherish that family. And you try to make that connection. So that's been an ongoing issue on all of our border communities.
Thank you.
Very bien. Ya, bueno, ya está.
Yo quiero hacer un comentario que creo que es de los más importantes. Primero tenemos que incrementar la información internacional fronteriza. Hay formas, lo podemos hacer. No está fluida, no lo estamos haciendo correctamente. Y segundo, definir cómo hacemos los
I'll be a little
cercos
over 10 minutes.
sanitarios
We're supposed to be done right
fronterizos.
1:30. Are you right out there?
Gracias.
Well, thank you for those comments.
¿Alguien de los estados mexicanos tiene alguna pregunta a los ponentes o algún comentario sobre lo que estamos discutiendo esta tarde? Diputada Gaitán.
Buenas tardes. Al cruce de personas de Arizona a Sonora. Efectivamente, nosotros aquí en Sonora hemos evitado estar yendo a cruzar la frontera, pero sin embargo, de allá para acá cruzan muchas personas. Entonces, creemos que es un descuido por parte de nuestras autoridades fronterizas de no cuidar esos detalles, porque ustedes allá en Arizona y en toda la frontera han estado cuidando el pase de los mexicanos hacia Estados Unidos, pero más sin embargo, nuestras autoridades mexicanas no han cuidado ese detalle y van y vienen efectivamente y no les importa, o sea, es como algo inconsciente de no cuidarnos entre nosotros, porque ahí ha habido, pues, el entra y sales, entonces ha habido demasiados contagios aquí en Sonora. Bueno, no quiero decir que lo traigan de allá ni que lo lleven de aquí para allá, pero sí ha habido un descuido muy severo por parte de nuestras autoridades para permitir el cruce de nuestros paisanos. Esa es mi aportación. Muchas gracias.
Gracias, diputada Gaitán. Diputado Montes Piña.
¿Sí me escuchan? Si me escuchan, como les comenté hoy en carretera, quiero saber si sí tengo la recepción de parte de ustedes. De manera rapidita, gracias, veo que me sientan, gracias doctor. Bueno, como probablemente ustedes ya lo saben, pues en Sonora al día de ayer tenemos el registro de 32.496 casos totales por COVID-19. De los cuales son 2.868 lamentables fallecimientos. De estos 32.496 casos confirmados por la Secretaría de Salud, tenemos la cifra de 16.307 recuperados totalmente, exitosamente. Al día de hoy nos reportan 152 casos hospitalizados con cuadros de serios a graves, ¿no? Pues esa es la cifra. Nosotros en las principales fronteras que tenemos en nuestro estado, que son Agua Prieta, Nogales, San Luis Río Colorado, existe también Sonoita y algunos otros, pero no son de tanta relevancia. En todos los puertos se logró pues cerrar el ingreso. Como bien sabido, Estados Unidos cerró el ingreso de visitantes visitas no esenciales hacia los Estados Unidos, y eso pues, fue una acción atinada. ¿Qué es lo que no se pudo detener del lado de México? Pues en el caso de las muchas personas que tienen permiso para trabajar en Estados Unidos, pues ellos iban y venían. En algún momento, como ya lo hemos visto, pues tanto California como Arizona, que son nuestros estados frontera, pues fueron de los más altos, ¿no?, en contacto con Estados Unidos. California, uno de ellos más que Arizona. Pero el condado de Yuma tuvo un momento de crisis, que es con quien más compartimos por el lado de San Luis. Aún así, en Sonora se actuó muy eficazmente.
Diputado Montespiña, no se escucha.
Thank you, Representative Montes. Would anybody on the U.S. side like to respond?
I can respond to the dynamic that the representative was talking
Estoy con
about.
ustedes.
I don't know.
Yes, please go ahead, Robert.
Right, and so that is that dynamic that I was discussing, this what is essential and what is not essential, and the interpretation that our federal governments took. So northbound, CBP, U.S. federal government, which has that jurisdiction, really did clamp down. For instance, if a person from Sonora wants to come up shopping to Walmart, that's not essential. They're not going to do it. But if a U.S. citizen wants to go to Nogales, Sonora, and buy tortillas, they can go across. And so this is one of the tourism as well. I know that there's a lot of pressure, and so this is that dynamic that we're seeing, and it's very complicated because it is the U.S. federal government and the Mexico federal government that control the borders. And from the state level and the county level and the municipio level, yes, I think that we would like to see a bigger restriction on that movement. Understanding that commerce is very important, that keeps moving, and that businesses are able to continue, so that if somebody is living in Mexico and works in the U.S., they need to have that ability to come up, and vice versa. If somebody lives here in Arizona and needs to cross the Sonora to work, that's very important as well. But I think that really clamping down on that non-essential would slow things. Right now, the numbers have dropped in all of our communities. However, I will point out that Yuma County and Santa Cruz County in Arizona have the highest incident rate of the entire state of Arizona. And if you look at San Luis Rio Colorado and Nogales, Sonora, they have among the highest numbers for the state of Sonora in the border region. And so you can see that this mixture of people going back and forth, essential or non-essential, these are one community. And so I think what we've learned working with Secretaría de Salud is that it's not Arizona or Sonora. It's we call it the mega región. It's the mega region, and so you treat ambos Nogales and you treat Yuma, San Luis Rio Colorado together as one community, and you treat it as one community, and you try to look for solutions as one community.
Thank you, Robert. I believe we have Representative Bujanda from Baja California who has a comment.
Sí, claro que sí. Muy buenos días, buenas tardes a todos. La frontera de Baja California es algo esencial, que somos 6 fronteras hay en Baja California, 6 pases, y tenemos estos 6 cruces que hay en Baja California. es la frontera más visitada, la que tiene mayor cruces, que es San Isidro por Tijuana y San Diego, que son las zonas conurbadas. En esta petición o en esta consideración, el tema del turismo médico en Baja California es muy importante. Con nacionales de los Estados Unidos vienen a hacerse los servicios médicos, desde una operación hasta algo dental que pasa. Aquí el problema son las largas filas, que precisamente lo que comentan ustedes, lo esencial, sí, ellos sí los dejan pasar, pero cuando vienen hay largas filas que regresan a su país. Aquí ya hace como un mes hubo una persona fallecida, incluso haciendo línea para ingresar a los Estados Unidos. Esta persona ya mayor que tuvo un infarto, precisamente. Entonces, eso es lo preocupante. Sí, no es esencial, pero el turismo en Baja California, el turismo médico en especial, es muy importante y esto es la preocupación. Es mi comentario. Gracias.
Thank you, Representative Bujanda. Okay, now I will send it off to Chairman Medina for some closing remarks.
Thank you. So let's give a virtual round of applause for all our spectacular speakers today, the work they're doing in the great states of Arizona, Coahuila, and Texas. I want to thank all of those on the call today for their tireless efforts to address the complex issues inherent in our shared border region and for participating today. Please join us again in future virtual gatherings and contact Adi with CGS West if you have additional requests or questions. I look forward to our ongoing engagement in this binational conversation. And as Robert and Maria reminded us today, we must take care of both of our communities on both sides of the border. And with that, we are adjourned till our next virtual get together. Thank you all.